Hello, everyone, and welcome to T1D to 100, Aging with Type 1 Diabetes. This is kind of the beginning of a real informational webinars that I think are so important to our community, and I'm just so excited today. We'll be discussing memory health and aging with Type 1 diabetes. And a lot of the questions we've put in our Facebook group, it always shows up as one of our top concerns. If you've lived this long with T1D, you've done something right and you've worked really hard at it and you've been aware of all the parts you have to do. And there's a concern that as we age, we won't be able to remember those things as well or if at all, and then who takes care of us. This is a major concern because we're used to doing it for ourselves. And um, I'm beyond excited to be able to talk about this today. So let me take care of a little bit of housekeeping. I always do this. It's a medical disclaimer that says this presentation is for informational and educational purposes only. It is not intended as medical advice. Please consult your healthcare provider before making any changes to your diabetes management or treatment plan. And the rules for today, they're real simple. I don't like a lot of rules, but all questions are welcome. But please put them in the chat. We'll be taking all the questions straight from the chat, and that's your best way. We also have some from the registration, so we're all set for today. Please be respectful and supportive of everyone's experiences. This session is being recorded and will be shared on our YouTube channel probably by tomorrow if all technology works. There we go. Let's talk a little bit about T1D to 100. It is a community dedicated to supporting, educating, and empowering people living with type 1 diabetes for a long time. We believe that living well with T1D at every age is possible and that no one should have to navigate it alone. The reason we started this and the reason we exist and are growing so rapidly is that T1D community over the age of 50 is growing so rapidly worldwide, but the resources and the support haven't kept up or even started in some places. Aging with T1D brings unique challenges that deserve our attention, the community's attention, legislative attention, all that stuff, and we need to make that happen. We connect with people who truly understand what it means to live decades with this condition. And we're hopefully bringing cutting edge research and expert voices directly to the people who need them, and we're able to support that. I'm so excited about that. So today, you get to hear from a dear friend of mine and a brilliant researcher in the space of type 1 diabetes and aging. I've known Nancy for a long time, and I'm just so honored that she's a friend and that she's here to talk with us today. Dr. Nancy Allen is a nurse practitioner and researcher with 22 years of clinical experience specializing in diabetes care and cognitive neurology. She earned her PhD from the University of Massachusetts and completed a postdoctoral fellowship at Yale University in self-management of chronic diseases in vulnerable populations. She currently leads a program developing practical tools for older adults with diabetes, including the use of CGM and follow apps. She's also involved in lots of other research, and I'll let her speak to that if you like. But our topic today is memory health and type 1 diabetes. So with no further ado, I am going to stop sharing and I'm going to turn this over to Nancy, and take it away, Nancy. Thank you so much for being here.
All right. Well, I'm going to go ahead and share my slides. I think it's allergy season, and see all these flowers that are surrounding me. It's like this pollen's crazy. Just kidding. Anyway, yeah. Okay, here we go. And I have my slides up. Well, I don't actually, okay, there we go. And let me just I got to move you guys' picture out of the way so I can get at this presentation mode. There we go. Oops. All right. So I am excited to be here to talk to you about memory health in older adults with type 1 diabetes. And This is something that is just a passion of mine. And if you know me, you can make me mad by saying there's nothing you can do about it when you have memory problems. Because guess what? That's just wrong. So there's lots of things you can do. And so this is why I have a passion for talking about this. So there was a brand new study out, 2026, from the All of Us cohort study, and it showed that individuals with type 1 diabetes did have a 2 to 3 times higher incidence of developing dementia than the general population. And, that can be very scary. Um, and yet, having information can also be very powerful because there's lots of ways to delay the onset or the progression of any change in your cognition. There was another study done in 2018, and this was a smaller study, but it broke it down. This was type 1 diabetes, and it broke it down by A1C. And those that had a real high A1C had an 80%, almost 80% higher risk of developing dementia. And those with an A1C between 8 and 8.9, you can see a 65% higher risk. But if you've got an A1C of 7 or less, you've got a 45% lower risk. So that should give many of you hope. Now, a lot of people ask me, so why is it that, we're developing, why do we have this increased risk? Well, we know that having a lot of low blood sugars can cause cognitive decline. We know that having a lot of high blood sugars can cause microvascular damage. And you've got white matter in your brain, and it can cause lesions in the brain there, having these chronic high blood sugars. You can also have vascular dysfunction. I mean, the blood vessels that are in your eyes, in your kidneys, or in your brain. And so, if you've got any type of blood pressure or any type of vascular problems, it can also lead to a vascular dementia. They think that there's something going on with the insulin signaling. I told you my voice. And that if you don't have enough insulin, it can impair the brain insulin signaling pathways. And then there's also another cause, which is inflammation, and elevated inflammation levels can impair memory-related brain regions. So there's lots of different reasons why, somebody with type 1 can have a higher incidence of developing dementia or cognitive impairment. Now, I think that it's really important. I'm going to keep admitting people when I see them pop up. A lot of times when you hear a statistic like that, then you're kind of getting nervous that, oh, I've had this moment where I can't remember somebody's name. And it's like, but that may just be normal cognitive aging. And normal aging does involve occasional memory lapses and slower processing speeds. But your daily functioning and your ability to do things remains intact. So, occasional forgetting, misplacing keys. Now, I've always had that problem. So if I started thinking that that was a problem related to my cognition at my age, then that would not be well-founded. It's just part of who I am. So there's occasional forgetting. There's forgetting because it's something you've never been good at. And you just have to recognize that, that's just who I am. You can have slower processing speed, so it may take more time to learn new things, to recall words or complete tasks, but still you get it done and you get it done accurately. Sometimes, you can't find those words and you might struggle to find that right word mid-sentence, but you're able to continue the conversation. You might forget the date. There might be some mild mood shifts. And, overall, with normal cognitive aging, you've got your independence that's completely preserved. Now, I wanted you to call your attention to this book called Breaking the Age Code. And this is by Becca Levy. And This is the science behind aging and what our society does to us. I have watched ever since I read this book, 45-year-olds, forget something and not be able to come up with a word. They don't even give a pause. They just kind of go right on. Now, when we get older, because our society has like driven in this message that, oh, you just lose it when you get older. We start to believe that. And it's not like that in every other society. So there's lots of societies that honor older people, and they actually don't even think twice about some of these mild things that I've been talking about. So our culture plays a lot into um, our, what we consider, oh no, we're losing it, we're getting older. And that book is a good one. So once again, I'm going to go through normal aging and then dementia warning signs. So memory loss, occasional forgetting names and where the keys are left, but remembering later, that's normal. But dementia warning is when you frequently forget recent events, conversations, or familiar names, and you still don't come up with it later. So your daily task and reasonings, making poor decisions occasionally, or needing help with complex technology. Well, a dementia warning sign is when you struggle with familiar tasks like cooking a meal, managing your finances, or driving to a known location. And that becomes very difficult. Communication, occasionally you'll pause to find the right word. With dementia, it's when it's frequent, there's severe pauses, there's word substitutions. So you come up with lettuce instead of, you know, maybe, a steak. I mean, that's a serious word substitution. Or confusion that disrupts a conversation. So orientation, it's normal to briefly forget the day of the week, then remember it. But a dementia warning sign would be becoming lost in a familiar place or losing track of seasons, time, or location. And personality and mood, mild mood changes or less interest in some activities. With dementia, you can see rapid personality shifts, including confusion, suspicion, depression, or severe agitation. So that's kind of, I hope that puts everything kind of in a little bit of context. So red flags for patients and care partners is when the memory loss starts to disrupt your daily life, forgetting things so often that it affects your work, your relationship, and your safety. How many times in the last year have you had to call the, fire department because you forgot the stove was on and it caused a fire? I mean, that's a disrupting daily life. Getting lost in familiar places, confusion about location even in well-known neighborhoods or in the home, difficulty managing medications or your insulin. And this is sometimes the first time that we'll pick up that there's a problem is somebody will show up in the emergency room and they've either mixed up their long-acting and their short-acting insulin, or they've taken 2 doses of their insulin, or they haven't taken their insulin for days because they've just forgotten. And then there's personality or behavior changes, sudden suspicion, aggression, withdrawal, or mood. And swings that are just really out of character. Problems with language, stopping mid-sentence, using wrong words, or difficulty following a conversation. And then worsening consistently over time. So the changes are really progressive, not just a one-off bad day. So when to seek help, it's really if it's disrupting daily life, causing safety concerns, getting progressively worse. Yeah. Now, as you all know, because you live with type 1 diabetes, is hypoglycemia episodes can really mimic worsen cognitive symptoms. But don't be, disregard that. That's just because you just didn't have enough sugar at that moment in your brain. But you can bring your CGM data and your glucose history to every appointment, and it would be ideal if your neurologist and your endocrinologist were working together. Okay, so preventing and slowing memory changes. This is what you can do to protect your brain health. So we know that your brain is only 2% of your body weight, but it's 20% of your body's energy. And so it's small, but it's very energy hungry. So high variability is linked to reduced memory, poor executive function, and shrinkage in the hippocampus, which is the brain's memory center. So when we look at an MRI, we're kind of looking at, what's going on in the hippocampus. And so if the brain, is not getting enough glucose or it's getting too much, then it can have that cognitive impact. So once again, with high glucose levels, it can affect the blood vessels in the brain, which can reduce the blood flow, and that can speed up brain aging. Now, you can also have the low glucose, which will trigger what's called a metabolic crisis for the brain cells, and it can impair attention, memory, and processing. And then there's that glucose variability. And I know many of you are tech savvy, so you know exactly what I'm talking about. So it's those frequent ups and downs, and that can be linked to brain fog, slower thinking, and an increase in Alzheimer's risk. So basically, stable glucoses, which, that's really hard to achieve when you have type 1 diabetes, but, just, doing the best that you can, knowing that you're not as good as a pancreas. And that's what you can do. And that is a lot. So the other things that you can do I used to say this is the most powerful drug that I can prescribe to you. And that is regular physical activity. And it's impressive that regular aerobic exercise, it increases the blood flow to the brain and really supports the growth of new brain cells. So the recommendations is to aim for 150 minutes of moderate activity per week, and walking counts and getting your heart rate up, maybe, have your breath quicken. Other things that you can do is there's the Mediterranean Mind diet. It's rich in vegetables, fish, nuts, and olive oil. And this is associated with lower dementia risk and steadier glucose levels. And you want to limit ultra-processed food. Now, I don't know if any of you have ever tried to limit ultra-processed food, but I've decided just about everything is ultra-processed food unless you make it. So it's hard. Another thing is getting regular sleep and getting a minimum of 7 to 9 hours per night. You know, this is when your brain can clear the waste products that are linked to Alzheimer's. And poor sleep also worsens glucose control, which is kind of a double whammy. Another one, and we'll talk, I have some repetition in here, so it'll drive points home, but it's to treat sleep apnea. So sometimes if you're developing that fog, it could be due to sleep apnea. Social engagement. This is very powerful. Strong social connections and mentally stimulating activities build a cognitive reserve and a buffer that helps the brain withstand aging. Isolation is a significant dementia risk factor. And so be social. Avoid hypoglycemia as much as you can. Recurrent lows are strongly linked to cognitive decline. And I know that this group is very tech savvy, so, I don't need to talk to you about using your CGM trend arrows. I know a lot of people don't like to use them, but you don't want to have overly tight control either, especially if you've got hypoglycemia unawareness. And then the closed loop insulin systems. And then train a care partner to recognize lows and use glucagon. And in my work with older adults, I have been amazed at how many people they don't have glucagon around. And I highly recommend it, especially as you age, and then training that care partner. And now there's the inhaled glucagon and all kinds of different ways to treat a low. The blood pressure. Everybody says, oh, 140 over 80. Well, guess what? There's been this study that has showed, I think it was the Diabetes Mind trial, and your blood pressure really needs to be about 120 over 80 or less to protect those blood vessels. Managing your cholesterol, that's really important. And that will prevent that plaque from building up in the brain arteries. Smoking cessation, it's one of the highest impact changes for brain and heart health. And then regular checkups. As we age, we're more likely to become at risk for atrial fibrillation, which increases the risk of stroke and dementia. Okay, so detecting memory changes and getting evaluated. It's how to notice, track, and formally assess cognitive changes. This is like, okay, I have concerns. You've told me a little bit about it, but I'm still worried. So I'm going to tell you that I've worked with a lot of endocrinologists over the years, and they don't want to do cognitive screening. And I've worked with a lot of primary cares, and they don't want to do cognitive screening. And I find it very frustrating. And a lot of this boils down to what do you do with the results? And I'm going to tell you what you can do with these results. But first, we're going to talk about it and what you can ask for. So there is a test called the SAGE. It's a self-administered gerocognitive examination. It's 12 questions. It's a 15-minute paper and pen test. You can just look it up on the internet and it will come up. And you can take it at home. Just don't cheat. um, you know, and then, you can find the answers there. And, certainly if there's concerns, you can take that into your primary care doc, or you can try with the endocrinologist, but they'll probably look at you like, I don't know what to do with that. Um, but there's also this mini cog, which is just a 3-minute test. And it just is a 3-word recall combined with a clock drawing test. And that is so brief that your primary care should be able to do that. Now, once again, you have to ask them for the results. And if it was abnormal, there are more tests to do. Once again, these are just screening tests. They're not diagnostic tests. So then there's the brain test, and this is a digital scientifically validated cognitive screen taken at home on a tablet or a computer. And then there's a clock drawing test, and you can find that at the Institute on Aging. And then there's an 88, and it's an 8-item tool for families and friends to flag changes in memory, problem solving, and daily functioning. Now, a lot of times, in the cognitive disorders clinic, when a patient came in, we required them to bring a care partner, because care partners oftentimes have an insight that maybe you wouldn't have. And then there's actually these informant interviews and these different, questionnaires that the care partner can take. And it's kind of like, yeah, this is what I see. So I would say about a third of people with changes to their memory aren't aware that they have any changes. And so, having a care partner who can speak to it is really helpful. Okay, so when a patient comes in, when you go in, this is what you would expect to get a formal evaluation. A thorough medical and history review. And this would be your medical history, your diabetes history, the medications that you're taking, information about your sleep, your mood, and any recent changes noted by you or your care partner. And then you can oftentimes, if it's a good center, such as a geriatric practice, a memory care center, things like that, then they will go ahead and do thorough cognitive testing by a neuropsychologist. And these tests typically last between 2 to 4 hours, and they will test your memory, your language, your attention, your processing speed, your visual spatial skills, and your executive function. And it can really give an amazing picture of where your strengths are, maybe where your weaknesses are, and maybe that there's no problems at all. And then there's lab work and brain imaging. So there's blood tests, a brain MRI or CT. Now we have amyloid PET scans. Um, and, having white matter lesions isn't always diagnostic of something horrible. Migraine sufferers have lots of white matter lesions. But in matter of fact, sleep apnea, you can have a lot of white matter lesions. So there's many causes. So once again, all of this has to be put together. And then that's where this evaluation report comes in. And, if there's a diagnosis, then you can figure out what's going on, and figure out your strengths, your weaknesses, and then the recommended next steps. Okay, so who to see? Well, like I said, a neuropsychologist, that's the person who administers and interprets comprehensive cognitive testing. Usually you see a neurologist who's specialized in cognitive disorders. Sometimes I find general neurologists, matter of fact, they referred to the cognitive disorders clinic all the time. And they were neurologists and they were referring to another neurologist. So I guess I'm here to say that not all neurologists can evaluate memory problems. Um, Sometimes it could be a geriatric psychiatrist, um, and a geriatrician, and that's a wonderful option. So you can ask your primary care or the endocrinologist for a referral, and they can point you to a memory clinic or an academic medical center. And that's how you get started. This process can take a while. Oftentimes these clinics are backed up, but stay the course and then put yourself on a cancellation list. The endocrinologist and the primary care, once again, their job really is to order some of these baseline cognitive tests. They're just screening. They can order those baseline labs. They can make the referral, and they can share the CGM and the glucose data with the team that they refer you to. Okay, so if you're getting a sense that maybe things are changing, these are some of the things that you should do, right away, and we should all just do it anyway. And that's, um, I mean, you turn 60, you should probably start doing these things. Figuring out the durable power of attorney, your health proxy, your advanced directives, your living will, existing wills. Um, you know, Documenting your insulin regimen, we know that changes, but at least, having some of these CGM settings, your emergency protocols in writing. And I know, Joanne, you talk about this a lot. Training a care partner to recognize hypoglycemia and administer glucagon. Ensure backup supplies and contact information for diabetes teams are accessible, and create a care transition plan for if or when self-management becomes too complex. And then I should have read this in order since it's numbered 1, 2. Oh, well, I mixed it up. But organize your accounts, your assets, your debits, your debts, and your insurance policies. And work with a trusted family member or financial advisor, and understand Medicare and Medicaid coverage, and explore long-term insurance options early. Premiums rise significantly with age. And then care planning, research the local memory care programs, the adult day care centers, and in-home care options. And I know some of these, this is like a whole nother talk that we could have about, how do you go about doing this and how much work there still is out there. Identify and find your support caregivers, and then connect with a social worker through the Alzheimer's Association or an elder care locator. Okay, so how do you treat memory changes? These are some of the treatable causes of memory changes. If you've got any type of thyroid problem, could be hypothyroidism, it will cause you to, you'll be cognitively foggy until it gets treated. Depression can mimic, uh, dementia. Polypharmacy, this is another one. And we did all of these things when somebody came in. This was part of that history that I took. We would go through common medications. There's this list of medications that you should not be taking over the age of 65 because they can cause cognitive impairment. And the name of that list is the Beers list, and you can get that online. And there's drugs like, the class one antihistamines like Benadryl. Often they're marketed as sleep agents. Yeah, the sleep aids, the bladder drugs, the muscle relaxers, all of these types of drugs can impair cognition. So reviewing the Beers criteria list and then, identify some of these medications and then eliminate some of those offenders. People can have vitamin B12 deficiency, and this is essential for nerve function. And a deficiency can cause confusion, memory loss, mood changes. It's treatable with supplements and injections. And anxiety can overload the working memory and it disrupts your focus. You know, working with in behavioral therapy and medication can really reverse, this anxiety and help people to clear their cognition. Chronic alcohol use, I saw quite a few people come in and they were drinking quite a bit. And, just even reducing that alcohol intake over time can start to clear um, the cognition. Sleep apnea, and this is repeated overnight oxygen drops. This can impair your memory, and CPAP therapy. Within 3 months, people are thinking more clearly. And within a year, it's like if they had that, white matter um, buildup in their brain, it can be cleared out. Not, I can't promise it, but that's typically what happens. But it's always impressive when you treat someone's sleep apnea, how that can really reverse things. And then infections. Infections can cause, cognitive impairment. So urinary tract infection, pneumonia, and other infections, this can cause a sudden confusion and delirium that resolves with treatment. And then another big cause is severe dehydration. Even mild dehydration can reduce your attention and short-term memory. So I always say, drink up and keep going. So the medications, this is why people say that there's nothing you can do for dementia, is because we don't have a perfect pill that you can take. But great stride is being made. So we have these old drugs, these cholinesterase inhibitors. They don't work all that great, and they can slow some symptoms. Um, we've got the nimantine and Namenda. It's used for moderate to severe Alzheimer's. It doesn't even work all that great. Now, what's cool though is they're working on these anti-amyloid therapies, and this is where you go in and you get an IV infusion, and it targets the amyloid plaques. And it's currently, if you get a diagnosis and you're in the early stage, you could be eligible for it. A lot of people are very nervous about these medications because they like right here, it says, brain swelling, bleeding, um, and you have to get a brain MRI before you start using it. And so a lot of people have been very afraid to start it. Rightly so. Those are serious, right? However, there's more than 30 of those drugs on the market. And you want to know why? Because these first generation drugs definitely caused these problems, but they figured out a way to take it across the blood-brain barrier with a carrier agent now, and it's not causing this, what they call ARIA, the brain swelling and bleeding. So, I mean, there's hope, and they're getting there. One of these drugs is these newer drugs that doesn't cause all these bad side effects is in what they call stage 3 clinical trials. So it's coming. And, uh, there's no disease curing option yet, but still there's, a lot of different things besides just drugs that you can do to take care of your memory. So you probably got that, you want to manage the glucose as best as you can. I never use the word control, because if you were a pancreas, you could certainly control your diabetes very well, but the best you can do is just manage it. And I know a lot of you are using technology. And so that's the other one is if you're not using technology, go ahead, get started. It's working. We've made a lot of strides. It's not perfect. I mean, there's a lot of things that we would love to yell at the technology companies that they've got to do better. But when you're trying to think about, your cognitive health, it is good to, have some of these tools. They are making a difference. And then care team coordination between the endocrinologist and neurologist. I never saw much of that going on, but you can always push for that. If you are having cognitive issues, then your regimen can be simplified so that it's easier to follow. There's lots of ways of doing that, and that doesn't always involve, completely taking away your technology. It could just be simplifying some of the different medications. And once again, I can't say enough. You've got to review all medications for their cognitive side effects. And this is one thing that we always did is we always engaged with the social workers very early in our clinic. And if you're in seeing your diabetes team, you can work with your diabetes educators. However, I'm still trying to educate the diabetes workforce. And I'll be presenting at the Association of Diabetes Care and Education Specialists on a couple talks with cognitive impairment and diabetes this August. So here's some of the other things that you can be doing. So structured brain exercises. You may have heard on National Public Radio or seen in the news programs like Brain HQ. It's people that did 10 hours of these brain exercises. 20 years later, they still had a 25% less risk of developing dementia. That's pretty important. And what they found was it was the processing speed tests that made the biggest difference. Dual task activities, so combining mental and physical activity like dancing and Tai Chi, that shows a stronger cognitive benefit. Learning new skills, hobbies, languages, or instruments can, strengthen the neural pathways. It's not shown to be as strong as getting regular physical activity, but it still is important. Digital tools, apps, and online platforms allow structured, trackable cognitive exercise from home. If you're feeling anxious or depressed, cognitive behavioral therapy, putting some of those coping strategies in place so that, as maybe your brain changes over time, the change isn't as, what should I say? Devastating. I think devastating is the word because you've got some of the coping skills and others around you are a little bit prepared. Reminiscence therapy, that can really improve mood. I know that I like to talk about, do you remember when? And, it can help also with connection in those that have memory loss. Occupational therapy, this can really help you to maintain your independence and, maximize your environment. And then getting education on what to expect and how to cope, which really reduces stress and improve outcomes. That's why I say just get information. It can help. There are peer dementia support groups, the Alzheimer's Association, and they have safe spaces to share experiences. There's T1D specific support groups that understand the dual burden of diabetes and cognitive decline, such as what we're doing here. And then there's caregiver support groups. The Alzheimer's Association puts on a lot of these. And then there's online communities. Then the Alzheimer's Association has a lot of these diabetes online communities. So resources. I put together a slide here, different things. The Alzheimer's Association has a really good, it's called ALZ Connected. And it's got like all kinds of education modules. But there's also all kinds of other things here. And then here's some of the diabetes and brain health resources. So I'll make these slides available All right. Now we get to do question and answer.
Okay, I'm sorry, I had to find the unmute button. It always gets lost. That's awesome, Nancy. Thank you so much for all these resources. Um, and I think Joanna and I have both been trying to drop some of them. I just grabbed that ALZ connected resource. Some of them into the chat, but as you said, we'll definitely release a full list of the resources. And you said, are you have a document that you made or?
I'm happy to share these slides. I have a feeling, people are going to want to look at the slides. I mean, as
Yeah,
opposed to saying, "Oh yeah, she presented it and I remember everything." I can't do that.
who
So yeah,
can?
I'll
Who
just make it
can?
available. Yeah.
Um, okay, well, that was amazing. We did have a couple questions that were submitted beforehand, and a lot of them were within the same themes. But I did want to point out that on this call today, we have over 1,300 years, for those who typed in how long you've been living with T1D, 1,300 years just on this call of lived T1D experience, which is incredible given how many people are on this call. The average number of years is 49 years living with T1D, and the longest, two people have tied at 71 years living with type 1 diabetes, which is just amazing. So I love to shout that out because it's so unique to this group and this audience. Um, a lot of the questions that were submitted ahead of time kind of fit into four buckets. A lot of it was you did a great job covering. One of the questions I thought was interesting was, you covered the difference of, people with T1D experiencing dementia or more often than people without. But Linda asked, do people with T1D tend to see more mental decline earlier than people without diabetes?
Oh, that is a good question. That is a really good question.
Yeah.
So there's actually some new research into this, and it just the American Diabetes Association just came, they come out with new standards of care for diabetes every year in January. And they've actually defined a new syndrome. It's too bad I don't have that in front of me. I just gave this talk last Friday to a bunch of social work students, but they're not seeing changes in the brain, um, and it's but they're describing it as some cognitive changes at an earlier age.
Mhm.
But it's not Alzheimer's and it's not a vascular dementia, and it's just they're calling it a diabetes. A cognitive change. And I wish I had that other slide set up because I can't
Yeah.
remember the actual term and all the descriptors. But that is some new research that's being done now. That's once again, I'm going to say that um, overall, you know, there's early onset dementia, which is before the age of 65. That's by definition. And that's oftentimes like there's a genetic component to that. And people with diabetes do have a higher incidence of Alzheimer's disease and a vascular dementia. But like I said, there is this new, they're calling it a diabetes cognitive change that does happen earlier. But for the most part, it's 65 and older.
It's funny, I'm not a scientist, but when I hear you say that, my immediate thought is it's diabetes fatigue. It's being mindful for so many years, so intensely, and with newer technology, intensely doing technology and all the changes it takes. Doesn't surprise me that they have observed something that doesn't show up in the brain, but gosh, sometimes we feel it.
Absolutely. And like I said, that's brand new. And I had not seen that before, and I haven't looked at the science quite, yet, but there was only like I think one or two citations with it. So um and I figured since I'm not sharing my screen, I can go back and pull up that slide and I can give you exactly what I told those social work students about it because I was speaking to them about the standards. Um, and and what I said is, people with diabetes need social workers and they need you to be investigators. So I will get that. And here it is. So they said, um, okay, that's not it. Diabetes related dementia, that's what they're calling it. And it's characterized by a slower progression of dementia, absence of typical neuroimaging findings, advanced age, this is not young, elevated A1C levels, long duration of diabetes, and this seems like a silly thing to say here, high frequency of insulin use. And that probably is because they're encompassing type. Yeah, I was just frailty, sarcopenia, which is muscle loss, and then loss of muscle strength. So that's what they're calling this diabetes-related dementia. But once again, it has advanced age. So it's not to answer your question, it's not necessarily a younger onset.
Interesting. Amazing. And we can add that in both the post-talk resources that we send out to folks as well. Let's see. Okay, Riva asked, what's your opinion on red light therapy as it's been shown to reduce symptoms of Parkinson's and Alzheimer's?
Um, you know, I will tell you that Joanne actually asked me this question. I probably should have gone in and done more research on it. I think it's an emerging therapy. Um, you know, and part of this is you have to realize that I am a scientist and, I get immersed in how much body of science is there for something, and so it's kind of like, when there's an association, does that mean it's cause and effect? No, not necessarily. So it's kind of what I would say is I think it's an emerging, you know, technology, an emerging treatment therapy. I can tell you that I saw in my practice in the cognitive disorders clinic so many different things that people were doing that were marketed to them to prevent dementia or to stop dementia. And they were spending a ton of money. And I remember just thinking, and I didn't know how to say, there's science isn't behind that. And if there was, we'd all embrace it and nobody would have dementia. But, that's hard to say. So I would say keep your eye on, this therapy. I think it's emerging, and let's look at the science. And then be very cautious with how you spend your money because I've had that marketed to me. It was 2 years ago. They wanted to sell me this really expensive red light therapy device. And I kind of went, yeah, no, I'm not going to do that. So be careful until the science is there.
Nancy, I want to cut in with a question that came up on the side here that's related to this. And I have the same question myself. What about Nariva and Prevagen, these things we see advertised on television that are supposed to help with memory loss?
Um, and I don't watch TV, so I'm at a disadvantage here. Um, I think that there is the Prevagen, there has been some science with that. I'm not as familiar with the Nariva. Um, Once again, I would love to say that, the last time I talked to a cognitive neurologist that they were like, everybody should go get this. They weren't. Um, but I think that there's, once again, some science. You know, we still just don't know a lot. And, you know, I would say that I should come back. Joanne, you'll have to invite me back. And I'm gonna show you the science on red light therapy, because I can do that. I can dig it up. And I can dig up, the science on Nerviva. Is that how you pronounce it? How do you pronounce it? Nerviva? Nerviva.
Nariva, I think it's
Nerviva.
pronounced.
Oh, thank you. But Prevagen definitely that's been around for a while. So yeah, once again, if it was working really well, everybody'd be on it and nobody would have any problems. So I think that these are emerging therapies.
There are
Thanks.
two questions on the same topic that I sit here and wonder about sometimes is glucose variability.
Mhm.
And And how do you define that if I go to an Easter dinner that's carb loaded and I say I can manage it and you can't because it's really hard to manage and you're up for 10 hours out of your range? Or if you're up for 2 hours, is there some sense of what this variability is or how frequent? Is any way of quantifying that?
I mean, on your ambulatory glucose profile, you've got that glucose variability. And, once again, just trying to keep it, depending on, which device you're using, but, like 37 or less, that's the goal, that's the target. I mean, I think more than anything, you just do the best you can. And you can't expect perfection and you can't beat yourself up. I think you just do the best you can. And you should go eat your Easter dinner and you should, make some decisions around it the best you can. And, but if you're running above 9%, then you have to be willing to accept what I showed you, like on one of those first slides, that you're going to have a much higher risk of having dementia.
Okay, so you could have a chocolate Easter bunny, but maybe the ear and not the whole bunny.
Well, just, and everybody's different. That's one thing. In 1999, when I started working with, continuous glucose monitoring, that's a long time ago. I can remember just marveling that somebody could eat cookies and it wouldn't affect them. And other people would eat a cookie and it would be like, oh my goodness. So it's knowing the way your body responds to certain things and making decisions and sometimes giving yourself a break and knowing just going up for 10 hours is not going to be the end all be all.
I put in a question because I'm curious about this. Are there ways to discuss this with a care partner? Let's say I have concern and I bring my husband in, who I know instantly is going to out me. Are there ways to bring up the topic with your care partner so that you can tolerate what you're hearing and you don't end up in a fight or in a worse position because you've discussed it? Are there scripts or
Mhm.
ways to bring this up?
Yeah, so I actually, and that's some of the research that I do is and Joanne, you've heard me say this. It's, how can you share your continuous glucose monitoring data and not kill each other? How's that for a scientific explanation of my research? But it's true, it's like I think that the way that this research it's with a diabetes care and education specialist, and it's, kind of having that person facilitate the conversation of, I'm going to ask you to share your glucose data, with your care partner. And from your perspective, when you have a high glucose level, what would sound supportive to you that your care partner could say? And, it's not, how long have you had type 1 diabetes and you haven't gotten this figured out yet? You don't want to hear that, right? No, nor do you want to have them contact you within, 1 minute of the alarm going off, right? So setting up those boundaries and having those conversations. Now, the same thing's true when it comes to your memory, is being able to say to that person, your care partner, is I want to talk to you about something that I'm very concerned about. And I am going to ask you for your support. I'm also going to say what won't be supportive to me. And, and I actually had to do this with a girlfriend this weekend. And I had to say, I need your support. And I don't want to have you say something unsupportive to me right now. And what would be unsupportive is blah. And I told her. And so I think that sometimes, saying this is how I want to be contacted, this is how long I need to deal with it myself, and this is, what I need to hear from you. And, going and having some of those conversations. When it comes to your memory, Joanne, what would feel supportive to you?
Exactly what you said. I am concerned. I was out at a meal and we ordered dessert and I'd already pushed my buttons and my husband turned to me loudly and said, "Do you really want to be eating that?"
Oh,
He actually said that. And I just turned to him, smiled, and said yes. And we had that discussion in the car going home, saying those words should not come out of your mouth. They don't land well. They're ineffective. So I think it's educating what works,
yeah.
and it's always an education.
Right, right. We know from large trials like the Dawn study, that care partners do want to be supportive. They just don't know how. So, I think sometimes saying there's helpful and there's harmful things. There's supportive and there's unsupportive things. Here's what could be helpful.
Mhm. Absolutely. There was an interesting question about adult endocrinology clinics that integrate cognitive brief screenings as a part of ADA standard of care guidelines.
They're supposed to. I have just never found one. So good. I'm so glad to hear it. Thank you.
Okay, so there's not really a resource
You
that
mean,
we.
oh, I thought you were saying that there is a clinic that was doing it.
No, are there these clinics that we're.
Oh, no, not to my knowledge. No, all I've had is pushback from endocrinologists. I mean, incredible pushback. So much so that I haven't finished this grant, but I wrote a grant and I was going to, and they did do this in one study with VA patients who have a much higher incidence of having cognitive impairment. And people took that self-administered gerocognitive exam and mailed it back, and then it was scored, and then they were sent a list of questions to take to their primary care provider. I want an MRI. I want my vitamin B12 tested. I want my, thyroid tested, and, screen me for depression and anxiety, screen me for the, at any rate, and then let them go seek the care because they've literally told the primary care what they want. So it's patients taking ownership. I'm like, okay, fine. None of you are going to, take and do what you're supposed to by the standards. So I'm going to go directly to the patients. So yes, I haven't finished that grant yet.
Maybe we write up a cheat sheet on what to talk to with our care partners. Maybe we do a thing similar to Bill Polanski's list of how to say things, just purely how to interact with a care partner. 10 items, that'll cover it.
I would love it. Yeah.
Are you
Um,
talking about the etiquette card, Joanne?
Yes,
yeah.
absolutely. Absolutely. It's good. It's well
It is
done.
good.
And we don't always know what to say, and we are on the verge of maybe being edgy or unhappy with what's being said to us. So we're not smooth in how we push back always.
Does.
I want to thank everyone who joined. These are not easy discussions. I don't think you could have a better speaker. I'm sorry, I am biased, but this is what we know and what we can do and talk about and share with others. And Nancy, my gosh, thank you, thank you, thank you so much. And I will also share some of the resources we have, and I will be sending that out along with the video when it's released. Thank you, everyone. Have a wonderful evening. Nancy, thank you.
Thank you, everyone. This was a lot of fun. You guys have my heartstrings. I love you all.